In June of 2015, I was introduced to a young man who had a medical condition called drug-induced schizophrenia. 5 years prior to our meeting, he had used drugs for the first time and used an exceptionally high amount of medication or of a drug that caused him to have hallucinations. And what's interesting about his case, and part of how I got involved, is that from that time on he persisted in having hallucinations. At the time we were introduced, treating addiction was not a big part of my practice, but a friend of mine who's a psychologist, a clinical psychologist who worked at a drug addiction center, asked if I'd become involved because this patient's depression was so severe. What was remarkable is that for 4 years, essentially, he had lived in an inpatient facility of one sort or another, trying to be treated for his now drug addiction, as well as his hallucinations and psychosis. In an attempt to treat his depression, we looked at the neurotransmitter balance of his brain, and it was clear that he was very low in dopamine and very low in serotonin and exceptionally high in dopamine. So we determined that we would give him some amino acids. Amino acids are the building blocks for neurotransmitters. We gave him intravenous amino acids, and what was remarkable, we were doing this to try to help his depression. Not only did it help his depression, it made all the difference in the world for his addiction. For the first time in over 1.5 years of not using drugs, he said that his brain had changed and he didn't have a constant craving or desire to use drugs any longer. It became clear that we had done far more than help his depression. We'd actually helped his whole brain, and this biological process of addiction that he had developed was truly changed with the application of amino acids. So with that background, I started to look into addiction, and addiction treatment models are changing, and thankfully that's the case. The old model of addiction is counseling and self-control and white knuckle the fact that this is hard, and perhaps some medically assisted treatments if you happen to be addicted to opiates or alcohol. There really is a new approach to addiction that's on the scene now, and that's that addiction is a biochemical, a neurochemical disease. It's a real biological disease, just like heart disease or diabetes. This isn't a moral failing. This isn't a weakness of the patient that they just really want to have that thing. But there are neurochemical pathways that become entrained, and there's absolutely a part of this that is psychological trauma that puts someone at risk for having this. But the neurochemical pathways are critical to help someone entirely overcome addiction. So again, it's not a moral failing. It's a biological disease, just like if you broke your leg. Now, one of the big things currently is what's called medically assisted therapy. And while this is important, I think it only scratches the surface of the medical side of addiction. Currently, what medically assisted therapy really refers to is when a patient has an addiction to an opiate, heroin or Percocet, something legal that's prescribed or something that's illegal, what we try to do for the patient is give them a better, safer opiate. So switching a patient from heroin or Percocet to Suboxone or Methadone. There's certainly benefit to that, because patients that are on Suboxone are taking a medication that both turns on and then turns off the receptor, what's called the mu receptor. And so the propensity for addictive behavior goes way down, because they don't need more and more and more of the drug with every passing month and year. So is it better than their addiction? Absolutely. Methadone's an interesting approach to medically assisted treatment. This is a really, really long-acting opiate, and so while the patient is taking short-acting opiates, they're getting these spikes in their dopamine levels, and so the addiction is being made worse and worse and worse. If we put them on something that's exceptionally long-acting, then they don't have the withdrawal, and since they don't have the withdrawal, they don't have a need to use again as soon, and they can simply take this methadone, take it 2 times a day or 3 times a day, and then they can go back to their job and be good parents or good students, whatever their stage in life is, and they can survive. But the reality of both of those approaches is they're still addicted to an opiate. The brain chemistry hasn't changed. Every time they take that opiate, a higher amount of dopamine is excreted, and we haven't helped them with regard to the biology. The other aspect of what's considered medically assisted therapy is something that would block the opiate receptor in the case of opiates, or something that would make it very uncomfortable to drink alcohol, for example. And so naltrexone is that drug for opiates, and if a person has naltrexone, then an opiate won't work. And if they have an opiate on board and you give them naltrexone, they'll feel awful. It's like an immediate withdrawal. Essentially what that's doing is that's putting someone in what I would call medical handcuffs. Does it do anything for the biology of their brain to fix their addiction? No, it really doesn't do anything. So now they're addicted, but they can't use. That's good, because that means that they're not going to go out and break the law in order to get the drug, but it's bad because they feel awful. It would be like coming up with a solution for diabetes that prevents the person from going into a coma, but they have all of the side effects of feeling terrible the whole time. It's really not a very good solution. So that's medically assisted therapy right now, and even that isn't available to enough patients. So the reality of addiction is that essentially the part of the brain that's in charge of assuring that we pass on our genes becomes broken. There's a part of the brain that exists solely to reinforce certain behaviors, and that's because those behaviors help us pass on our genes. They cause what's called a physiologic reward. Inside the brain, that's a release of dopamine and endorphins. The list is pretty short. Food keeps us alive, so we have in the prefrontal cortex a memory that says, I should do that again. Sex, that helps us pass on our genes. We have a memory that says, I should do that again. Love and friendship protects us. So if we make friends, there's a reinforcement. And then what's called novelty or learning. And that's because the more we learn, the better we can do stuff. All of those things help us pass on our genes, and those are what are called natural reinforcers. That's why that part of the brain exists, to help us learn those behaviors and do those behaviors over and over. And this reward circuitry, at a very, very basic level, includes what's called the ventral tegmental area, which communicates to the nuclear accumbens, which then communicates to the prefrontal cortex. And in that pathway, there's a release of different neurotransmitters. And to keep it simple, I'll focus on dopamine, but it includes serotonin and GABA and acetylcholine and dopamine and endorphins. When each neurotransmitter communicates its message down that chain, then the prefrontal cortex, where we store emotion and memory, it hardwires that, and it says, okay, I'm going to do those things again. This is great. It helps us form appropriate emotion, relationship emotions. It helps us both drive and control our impulses, and it's really important for subconscious decision making. Well, we make a lot of our decisions subconsciously, and so if that pathway is healthy, we're going to make good decisions. So nerve pathways are fascinating. When we're born, in fact, before we're born, the amount of nerves that touch other nerves, they communicate, they're called synapses, is relatively low. And with each passing month, the number of connections goes up and up and up and up. And you can see in this slide that at 2 years, it's almost like every nerve is talking to every other nerve. Then we go through a thing called synapse pruning, where we start to realize, wait a minute, I don't have to have every nerve talk to every other nerve. I need to just have the most important pathways highlighted. And so we start to disconnect some of those things. What's fascinating in neurobiology is that happens throughout our lives. It happens the most in those first 6 years, 8 years of life, because that's when we're really learning how to walk and how to talk. And you know, when you're a baby, you learn how to swallow. All of those things are being learned. Well, if you learn a new language at age 30, you're going to have some synapse pruning. You're going to have some new synapses form. It takes actually about a month for that to happen if you look at the research. So in a healthy reward circuit, what's happening now, basically what you have is a nerve that in the nerve you've got a nerve body. So the nerve body has the nucleus inside of it. That's where all the DNA is stored. And then there's a long arm on that nerve that sends out messages. And then there's a whole bunch of little receptors that receive messages. So this long arm is called the axon. These little receptors are called dendrites. Well, this axon can talk to lots of other dendrites from other nerves. Okay? So the nucleus has the DNA. The nucleus is where stuff is made. All the receptors that are being made are being sent down this axon. All the neurotransmitters are being sent down this axon. Receptors are being sent up the dendrites. That's the basic anatomy of the nerve. Well, the next nerve next to it, there's a little space in between the end of the axon and the beginning of the dendrite called a synapse space. And what happens is neurotransmitters are dumped out into that space to communicate from one cell to the next. Let's see. So in a healthy reward circuit, what you've got is the right amount of the neurotransmitter, we'll say dopamine, being dumped out, and the right number of receptors to receive that. It works fantastic until we break it. Mood neurotransmitters that I mentioned earlier are going to be primarily dopamine, acetylcholine, GABA, and serotonin. What's interesting is we all are different, right? We have different fingerprints, we have different eye color, we look different. Our balance of dopamine, acetylcholine, GABA, and serotonin is probably distinct from each person, and so that can play a fairly big role in our personalities. If a person's more dopamine dominant, for example, they're going to be a little bit more type A personality, more ambitious, get things done. If a person's more GABA dominant, they're going to be a little bit more easygoing, more friendly, just take things as they come. If a person's more serotonin dominant, they're going to be more maybe that pacifist, maybe not quite as friendly as the GABA person, but very content. The acetylcholine personality is going to be a little bit more intellectual, more interested in learning details, that sort of thing. So we all are a little bit different, and I suppose that's the spice of life. But if we become deficient in any one of those neurotransmitters, then we also could have what I think modern medicine would describe as a disease state. If I'm too low in serotonin, most people know, well, that means I'm going to have depression. If I'm too low in GABA, that means I'm going to have anxiety. So these mood neurotransmitters